Good afternoon to our viewers, and thanks for joining us on this rainy day in Johannesburg. My name is Toli, and today in our Ask the Expert edition, we are talking to Dr. Laila Paruk, and we're also talking to Megan. We will be discussing being diagnosed with depression, then asking the question, then what? I'll be sharing with you their bio. Dr. Laila is a psychiatrist in a private practice at the Centonic in Saxonwold. She also works at Zamani Dual Diagnosis Clinic at Chris Hani Baragwanath Hospital, and she's a board member of SADAG. Megan is a support group leader for SADAG who supports people living with depression, anxiety, bipolar disorder. Her personal journey with depression has been shaped by her resilience, her compassion, commitment to challenging stigma while sharing hope. I wish to welcome both to this edition of Ask the Expert. I'm going to start this conversation with you, Dr. Paruk, and I just wanted to understand the depression diagnosis. When somebody is first diagnosed with depression, what does diagnosis mean, and what is happening in the brain and the body?
So, a diagnosis of depression means that a person is experiencing a medical condition that affects your mood, your thinking, your behavior, as well as your physical functioning, not just your feelings. In the brain, depression is associated with changes in neurotransmitters like serotonin, norepinephrine, dopamine, and these regulate your mood, your motivation, your sleep, and your energy. There can also be changes in your stress hormones like cortisol, which can remain elevated or become depleted, and this affects your memory, concentration, and immune function. More and more, we're learning about the role of brain networks in depression. So it's not specific or individual neurotransmitters, but how they all speak to each other and how different parts of the brain connect with each other. In the body, depression can cause fatigue, sleep disturbances, appetite changes, physical aches, slow movement, or agitation. So, depression is not just in the mind, we have to consider it a whole body condition.
Oh, I'm so glad you mentioned that it is in fact is a whole body condition. It's not just only in the mind. And that just makes me wonder, because we get this with most of our callers, what is the difference of feeling sad and having a clinical depression? There's always a confusion with our callers when they're calling into the call center.
So, sadness is a normal human emotion. It's something that we all have, and it's something that we all feel at various points in our life. And some people also consider it a protective emotion. If we're feeling in a certain way, it helps us assess our surroundings and assess danger, etc., much like anxiety. Sadness, in a normal sense, is usually linked to a specific event, and it tends to improve with time or support. Clinical depression, however, it becomes a clinical diagnosis when it lasts at least 2 weeks, and often clinically we see that it lasts much longer. It can affect your daily functioning, so that can be at work, at school, in your relationships at home. It might not have a clear trigger. So, going back to that biological underpinning of the disease, there doesn't need to be a loss or a death or a breakup of relationship necessarily. And it includes symptoms such as persistent low mood, a loss of interest, hopelessness, sleep and appetite changes, low energy, difficulty concentrating, and sometimes people have repeated and intrusive thoughts of death. The key difference between feeling sad and having clinical depression is severity, duration, and functional impairment.
Mm. So it sounds more like clinical depression really affects your functioning as a human being. It's not just as simplistic in saying, I'm feeling sad. Literally, it does affect how you do your day to day life. What would be a warning sign for somebody?
So, urgent help is required and needed if someone has thoughts of self-harm or suicide. It's even more urgent if they have a specific plan or an intent to harm themselves. They
Hmm.
feel hopeless or believe others would be better off without them. They sometimes you notice patients with severe depression can be very agitated or withdrawn and a functional decline. So they're unable to care for themselves. They don't eat, they don't sleep, they don't shower, they don't have energy to brush their hair. Any expression of suicidal thoughts should always be taken seriously and addressed urgently.
Mm, that's very important to hear. And on that note, I just want to draw in Megan. Megan, I would like to hear from your personal lived experience, which will give even a clearer understanding to our viewers about the depression diagnosis. When you were first diagnosed, what was the immediate emotion reaction that came to you?
Slowly, it was relief because now I can at least put a name to all the feelings that I'm experiencing because I don't know what is going on. But also fear because
Mm,
how do I explain this to family and friends who don't really believe that there is something like mental illnesses? So that was very difficult. And my children were still very young. So it made it quite a problem because I need to look after them, I need to look after myself. And then there's people out there who's judging and saying, you just get out of bed, you're just lazy. So it was a difficult time.
mm. So it actually sounds to me like it's almost like you're caught in between. You have this relief to say, oh, finally, I can make sense of what's happening in my world. But equally, you have this feeling of, what am I going to do next? This fear of, how do I even explain this? So, what was the hardest part about accepting this diagnosis for you?
Um, I think the invisibility of um, depression, not
Mm,
only depression, but all mental health issues, because no one can see that I have a mental health disorder. Um, because they would say, if you have diabetes, it's okay, you can take your medication, but I don't know that you have depression. I can't see it. It's not written on my forehead. So that also makes it very difficult because you're not feeling well. You don't want to get out of bed and everything just slows down. So
mm.
it was very hard.
Yeah, I can imagine what you're saying, Megan, because like you're saying, if you have diabetes, you can run a blood test and then you can say, look, you have tested positive for diabetes. But the
Hmm.
invisibility of having depression or clinical depression is that this is something that's happening, but you don't have an actual blood test that can say, this is what you have.
Hmm.
So that I
Yeah.
can imagine that would be difficult for you. What do you wish somebody would have told you in the first few weeks?
That there is healing. There is help out there. I can see a psychiatrist. I can, if I take medication, I can get better. I can feel better. That would have been very helpful. And just to say that I'm here for you. If you need to talk, I'm here without any judgment.
Mm. And I can hear how this, even just hearing your voice, it sounds like, it's not something easy to process, and it's not something quite easy to even share with your loved ones or people even at work.
Mm.
And I want to bring you in, Dr. Lila, to say, what are the first practical steps someone should take after receiving a depression diagnosis?
A great question. I think first you need to educate yourself about depression as a medical condition. And when I say educate yourself, there's so much information out there, and it's difficult to know these days what to trust and what not to trust. So I think the SADAG website is probably a good page to land and start, because that is vetted information and verifiable information. And then follow up with a healthcare provider to create a treatment plan. Now, in our country, that's not always, to access a specialist psychiatrist is not always easy in terms of resources. But your GP is a good place to start. They have the training to manage and to be able to assess depression. Our government health services are available. So there are psychiatrists in even in local clinics. There is mental health support. So follow up with a healthcare provider. And then it's really, really important. And I go on about this with my patients. I think they are so tired of me saying this, but establish a routine. So our brains like us to sleep at the same time every day, to wake up at the same time every day. It's not necessarily getting 8 hours of sleep or whatever. It's getting the same amount of sleep every day at the same time. Our brains like us to sleep when the sun is down. So you can't say I'm sleeping 8 hours from 8 a.m. to 5 p.m. Daytime sleep doesn't count, and it's actually counterproductive because of our melatonin. The melatonin system feeds into the cortisol system, into the serotonergic system. You need to sleep when the sun is down, and you need to wake up when the sun rises. Regular routine in terms of meals, light activity. Our bodies, like our brains, need regular, consistent activity. The fourth thing is to reduce isolation. So I'm not saying you need to be the life of the party, but even small social contact helps. And all the evidence in terms of what does that mean, it's about a sense of purpose and belonging. So whether that comes through your religion, like going to church or mosque, or through a sporting club, any place where you feel like you are a part of a bigger group, there's massive positive impact on mental health. And then to set small, achievable goals rather than overwhelming expectations. So, from not brushing your hair, not managing to shower, and not managing to eat anything but chicken nuggets for a week, we're not expecting you to run comrades in June. So, take it one step at a time. And the apple metaphor is quite helpful here. Nobody expects you to swallow an apple whole. You take a bite of an apple, you chew it, and you swallow it. And that's what you do on your recovery path. So the first weeks are about stabilization and support and not perfection.
Mm. You really touched on a very important one on the psychological education, just understanding the clinical depression that you have and how to best support yourself. And I think that's important because it's the information that empowers us and helps us to say, okay, I have this diagnosis. So what am I going to do? And how can I support myself? So often when we have callers, they would call in and they have some sort of resistance when it comes to therapy, medication, or both. So I just wanted to understand from your expertise, how do you decide whether somebody needs therapy, medication, or even both?
So that depends on a few different factors, and it's what we call a patient or a case by case basis. And it depends on the severity of the symptoms, how long they've been there, how functionally impaired is the patient. Are they able to work? Are they able to carry out their daily duties at home? A previous history, and then the risk assessment. That includes the suicidality aspect. So, if the depression is mild and maybe the first episode and hasn't been around a long time, it might respond well to therapy alone. And there's many forms of therapy, but contact regularly with a psychologist, preferably a clinical psychologist, is what we mean when we say therapy. Moderate to severe depression often benefits best from a combination of therapy and medication. And research consistently shows us that combined treatment outcomes improved outcomes in most severe cases. And nowadays, there's a lot in the media and in our thinking about what we call novel therapies. So there's the therapy, and then there's the medication, and then there's the third intervention, which is what we call interventional psychiatry. So it's things like electroconvulsive therapy, things like transcranial magnetic therapy. So these are machines that we use on your brain to help treat depression.
Sounds like there's a lot of innovation that's happening really to try to assist people as best as they can. And I want to call you back, Megan. I just want you, for me, when I'm absorbing and I'm hearing all this information that Dr. Lila is talking about, I'm just trying to hear your experience to say, look, you go to a psychiatrist, you're diagnosed with clinical depression. How do you even explain that to your family and friends who don't even understand what you're going through? Can you just share with us that experience for you?
Well, Zoli, I try to explain to them that I don't feel like getting out of bed. I don't feel like eating. Everything in my life just slows down. Walking to the kitchen, it should take me 2 minutes or a minute, but it literally takes 5 minutes. But eventually I had to pick it up because my kids want their breakfast in the morning. So, I had to just work through that. But whether my family understood, I really doubt that. They definitely or don't want to understand what is really happening.
So it's like there's a difficulty of understanding your experience. So it's almost like you required to tap into yourself, even though you're going through this depression, to still be there for the family, even though you are still struggling yourself emotionally. And I can imagine that will be something very difficult to manage. And what helped you the most in the early stages of your recovery, Megan?
No, I had to make that decision that I have to see my GP or my psychiatrist ongoing. I have to see a psychologist and take my medication, even though I really resisted taking medication. But, after when you really not feeling well because you didn't take your medication for a couple of days, I realized I have to be okay. I have to look after myself before I can look after anyone else. So taking your medication, seeing your psychiatrist, psychologist, and make sure that you stay healthy, that you eat healthy, do exercises, just go outside, stand outside, and ground myself.
Megan, you are definitely reaffirming exactly what Dr. Lila is talking about, having a routine, right? Taking your medication, doing therapy, right? And also taking your medication, doing both, and having a structure, a system that works for you on a daily basis. So, and you mentioned also, obviously, in the beginning, having some sort of resistance towards taking the medication. And I want to take it back to Dr. Lila. And I just want to find out, there's a lot of fear around antidepressants. Are they addictive? And how do they actually work, Dr. Lila?
So antidepressants are not addictive. I think I'm going to lead with that. And the definition of addiction is something that causes tolerance, meaning that you need more of the same thing to achieve the same effect. So if you took one pill today, in a week's time, you need 2 pills for that same feeling. That's what we call tolerance. And the second thing is dependence, meaning that if you don't have the substance, your body or your brain can feel it. So antidepressants do not cause cravings or dependency in the way that substances like alcohol and benzodiazepines do. So most commonly prescribed antidepressants, like what we call SSRIs, which are the selective serotonin reuptake inhibitors, they work by increasing the availability of serotonin in the brain. And why we tell patients that they need to wait a while before they start working is because what's happening is over several weeks, they help to regulate the mood circuits, reduce anxiety, and improve emotional resilience. So some people do experience side effects when starting or stopping the medication, but this is not addiction. It's the brain upregulating or downregulating to that serotonin receptor.
So obviously, everybody's different. They will react differently to the medication, but it does not necessarily mean that it's addictive, like you taking maybe some substance use like alcohol. So I'm glad you clarified that because most of our callers have that fear about antidepressant? And how long does the treatment usually take before you can start seeing any results or feeling better?
So, as I said, what we say to patients is that full improvement takes 8 to 12 weeks, but within the first 1 to 2 weeks, some physical symptoms, you'll start seeing that the trajectory is in the right direction. So people start feeling better. Mood and motivation take about 4 to 6 weeks, but recovery is gradual. It's not overnight. And so patients need to be patient, patients need to be consistent. And I think the reason that these medications have this reputation for being addictive is because the fear is that they're not addictive, but they are very powerful drugs in that they are mind altering. So they can do big things in your brain, and therefore they have to be used very carefully and very judiciously. But the other reason that people find that it's addictive or feel that it's addictive is because if you stop suddenly, your brain's not going to like it. So the way we start the medication, which is we start very low and we build up the dose gradually over a few weeks to a month, that's the way that you have to stop. You can't stop cold turkey. You have to wean the dose off really carefully with the help of your doctor. And so it's when people stop suddenly or when they forget to take it for 3 or 4 days, they get a headache, they get joint pains, they feel irritable, and then they're like, "Oh, I'm addicted to this." It's not an addiction. It's the receptor downregulation.
I see. So, Megan, when you're hearing Dr. Lila say this, were there days when you doubted the diagnosis or you resisted the medication?
Yes, I did doubt the diagnosis because it only happens to other people, not to me. But when you have all that feelings where you feel down, your mood is always low, you don't eat. Definitely, I had to accept that there is a problem, even though it is difficult to accept and sometimes also to understand. Um, I finally accepted it.
Hmm. So it sounds to me like it's a process to accept the diagnosis. It's not something immediate. Although it's a
Mm.
relief, it takes some time to really accept and start to accept and take the medication on a regular basis and go to therapy and do a combination of all the treatment. It's something
Yeah.
that really takes time. And Dr. Lila, I just want to bring you in and say, what should someone do if they feel that this treatment isn't working for them?
So, in psychiatry and with the antidepressant medication, there was a massive study done where they explored whether the medication works or not. And it was the largest study, and it was called STAR-D, and it involved many, many thousands of people. And what they found was that first line, so the first antidepressant that people choose, it works 70% of the time. So that means there's 30% of people, 3 out of 10 people, the first antidepressant does not work. And then you need to try a second one and sometimes even a third one. So if the treatment's not working, it doesn't mean that you are treatment resistant or that it means that we need to try again. And so people should speak openly with their doctor. Don't stop the medication suddenly, as I said earlier. So the doctor will need to review the dosage and the duration because we can't really say it's not working after 1 week on a quarter dose. So it has to be a full 12 weeks on the maximum dose before we can say the medication's not working. If after 12 weeks on a maximum dose is not working, then the doctor can consider switching the medication. The doctor can consider adding psychotherapy if it's not there, adding an augmenting agent, but also re-looking at those lifestyle and stress factors. So if we're giving you medication, but you're sleeping 2 hours at night and you're looking at a screen all night and you're drinking 3 liters of alcohol a day, we're doing everything we can on our side to regulate your mood. But then there's a million things that a person can do to dysregulate their mood, and sometimes not even intentionally. So
Mm.
it's all about communicating with your healthcare provider.
Dr. Lila, can you hear me?
Yes, I can.
I lost you for just a minute, a second there. So I am glad that obviously, if the medication doesn't work for you, it's so empowering to hear that you actually can go back to your doctor, go back to your psychiatrist, okay, go back and find out exactly what else can be done instead of saying I'm not going to use this medication. So that in itself is empowering, and then I think it's so important for callers to hear and our viewers to hear, so that when this happens to them, they feel that this medication is not working. The first thing you want to do is report, go back to your psychiatrist and find out how best can we help. And I just wanted to find out, can depression go away completely, or is it something a person manages on a long term?
So, by definition, depression is a relapsing and remitting illness. So, it's episodic in its nature. So, you can have an episode lasting a few weeks or months, you can get better, and then 3 years from now, you can have another episode. However, some people have more chronic forms of low mood, which we call dysthymia, which is quite common. And some people have more recurrent episodes, a couple of times a year, and they kind of fade one into the other. So, when we're aiming to treat, we're aiming to get full symptom relief. We're aiming for people to get back to functioning to pre-depression levels. We're aiming to teach coping skills, and to prevent a relapse, that it doesn't happen again. But sometimes it does. And then if the symptoms return, it's about patients knowing the symptoms and catching them early on so we can intervene early, so that, the longer duration of untreated, the harder it is to treat. So the longer you wait, the harder it becomes to treat, because I was talking about those pathways in the brain, they become more rigid and difficult to shake.
So what I'm hearing from Dr. Lila is that to deal with a clinical depression, you need a lot of support. There is the psychiatric support, the psychological support, there's what we eat, what our lifestyle. And I wanted to know from you, Megan, in terms of support groups, how do support groups help someone who's just been diagnosed?
Zoli, we create a platform for members to be able to come into a safe space where they can sit and listen to other people who's gone through the same, and they get that opportunity to say what they need to say to get all that that new now been diagnosed, maybe anger and fear, they can get that out in a safe space. So a lot of the members who come to the group would say that they can't speak to their family, they can't speak to their friends, because these friends or family just don't understand what is happening. So I think we make it a lot easier for people diagnosed with depression to come to a group every week to just sit and chat to each other and learn from each other.
So the lived experience in the support group does actually have a positive effect with the people in it, because everybody feels like they share the similar experience and are able to express themselves in a safe environment.
Yes.
What does living well with depression looks like for you today?
Living well is, for me, I feel a lot better. I eat better, I sleep better, and I can say to the members in the group, I know what you're going through. I don't know how you feel because we're not the same person, but I've also been there. I also stopped my medication cold turkey because I hear it all the time. So I've also been there. I've also tried not to take medication, and I can't sleep, but there is help. If you reach out, there's always help. Because a lot of the time members feel that there is no one, that they're alone, they are the only people in the world or person in the world who's been diagnosed with a mental illness. But when they come to the group, they realize that they're definitely not alone and that they can actually speak to other people who's gone through the same.
No, absolutely. That is very encouraging, Megan. So, Dr. Lila, we're almost at the end of our edition. So, I just want you to, if we have something for our viewers, our callers, that you can wrap up with regards to clinical diagnosis of depression. Just something that you can wrap up for us before we close off.
I think that it's great that there's such a focus on mood disorders. And I think we live in these unprecedented times when we have large amounts of access to information, but don't really know what to trust and how to trust it. And in an era of, never being alone, we find that people are actually very lonely. So it's about reaching out, it's about connecting, it's about staying connected to your communities, to your support structures, and about accessing help when you can. Thank you very much for the opportunity to speak.
Thank you, Dr. Lila, and thank you for Megan for joining us, and also to our viewers. And please do know that SADAG is here to give you support. We hear our number is 0800 567 567. It's a toll-free number. It's available 24/7. If you need some support, you want to understand how Megan's support group works, and you feel you know someone or yourself that should be in it, please don't be afraid to just pick up the phone and ask for help. Thank you and have a good day.
Thank you.
Thank you so much.
Bye.
Bye.
Bye.